Welcome, and thank you for joining us for our Elder Abuse Awareness webinar on geriatric teleassessments and adult protective services. I'm Natasha Pietrocola, Deputy Director for Community-Based Programs here at the Division of Senior and Adult Services, also known as DSAS. DSAS empowers seniors and adults with disabilities to age successfully by providing resources that support their independence. One way we help our older adults is by investigating and responding to reports of elder abuse, neglect, self-neglect, and exploitation. Today is World Elder Abuse Awareness Day, so we wanted to take the time to talk about the work DSAS's Adult Protective Services Unit does to keep the county's senior residents safe. Every year, our APS team assesses thousands of individuals in response to allegations we receive regarding potential elder abuse. Having a clear picture of the mental well-being of each client is critical to a successful outcome. So last year, we added a geriatric nurse to our assessment team. In 2020, the nurse assisted APS clients in more than 700 times, conducting more than 400 in-home consultations and completed over 200 behavioral and/or geriatric assessments. Today, we're going to take a look at some of the lessons learned after our first year of this new approach. We have with us today 3 experts who are very well versed in mental health, adult protective services, and dealing with older adults in general. We have Dr. Ronan Factora from the Center for Geriatric Medicine at the Cleveland Clinic, Larry Vavro, who's the Chief of Adult Protective Services here at DSAS, and Kelly Clemings, our Geriatric Behavioral Health Nurse at DSAS. Thank you for spending some time with us today for us to be able to share our insight into this program that we designed for APS clients in April of 2020. I'd like to begin our panel discussion with Chief Larry Vavro. I'm going to ask him a series of questions to help kind of gauge a better understanding of how this program was first initiated and why it came about. So Larry, can you tell us a little bit about what Adult Protective Services does?
Thanks, Natasha. So I think it's helpful to put things in perspective on exactly what Adult Protective Services does. I want to lay out the approach that APS takes when it's receiving a report. So there's really 3 key duties that Adult Protective Services has per the Ohio Revised Code. One is to receive the reports of abuse. The next is to investigate those reports to see if they're legitimate or not, if they're validated or not, and then to provide protection if it's found necessary or needed. The pillar to Adult Protective Services, and this is nationally, if not worldwide, the practice is a respect for a client's right to self-determination. Okay, that's a key component when we approach our clients. Respecting a client's autonomy is a key practice when we get involved in someone's life. So understanding in practice, there's even an understanding of this in the law. So in our law here in Ohio, as well as across the country, in Adult Protective Services law, it's clear that people have the right to refuse our services. It's spelled out that if a client can refuse our assistance if they so choose, and this can occur at the very beginning of our investigation, it could be during the course of the investigation and the start of the provision of services, or even near the end after we put pieces and parts in place to help a person, they can reach a point where they refuse our assistance. When that occurs, we many times have no choice but to end our involvement and close their case, whether there is an allegation of abuse found or not. The key component to that, however, is to respect that choice if they're refusing and they're doing it knowingly, okay? And that key component is probably the hardest part of our job, determining whether a person has that capacity to understand what they're refusing. Okay, that's where the APS worker gets down to some pretty hard work, okay? because they have to answer the question, how do we determine that a client has capacity to fully understand what they're refusing if it ever reaches that point? So APS, my workers and staff are trained to do some cursory assessments. They'll ask some mini mental questions, they'll do some exams to determine that. But in the end, if there are still questions raised concerning a person's capacity and we feel it can continue putting that person in harm's way, we rely on medical professionals to assist with this. Okay, so we initially reach out to a person's personal physician if they have one, but you can imagine we have some clients who come to us who haven't seen or received any medical care for years. Okay, so what we will do is we'll arrange for a capacity evaluation. It could be through a hospital, it could be through an outpatient geriatric psych eval program, or even possibly reach a point where it's an inpatient geriatric assessment that occurs. But we're going to try and reach a point where we can determine a person has capacity. And that help or that determination of whether they have capacity and whether it reaches a point where we need to determine whether we respect their right to continue refusing our help or if we need to go forward with getting them the protective services that they need. Now, I want to make it clear that every one of our clients that we run across don't get capacity evaluations, okay? There are some people who outright will refuse our services, yet that capacity assessment is a key part, a key component to whether we move forward with forcing protective services on them because they no longer understand the jeopardy and the danger they're in and the harm's way they are by continuing being in the situation they are in.
So that's wonderful to kind of understand that entire process and describe kind of a typical adult protective services client and what you guys are investigating in APS. Can you talk a little bit about the challenges that were presented recently with this onset of the pandemic?
So the pandemic, a subject near and dear to everyone's heart, especially in the service field. Back in March of 2020, we all know that the pandemic hit. We made some harsh choices at the county where we had to close our buildings, but adult protective services never ended. There were many changes in how all of us did business. Not only were offices closed, but many service providers who provided assistance in people's homes stopped doing that because they were fearful of contracting the COVID virus or either passing it on or getting it for their employees. There are many hospitals who shut down visitation to patients, so that was a barrier that we had to try to overcome. We had nursing homes that no longer allowed visitors and refuses to come in. We had media directives that were providing us information showing the limitations we had on being able to access people, as well as our own governor, Governor DeWine, who was putting directives and limitations on what we could do. So you can imagine the challenges that we had because part of adult protective services is actually seeing our clients. That's a directive that's built into the law. So face-to-face contacts were definitely a challenge for us, both from the client being able to or allowing us to be able to see them, but also the need to protect our own staff from being exposed to the virus. So we still, like I mentioned, we still had that duty. When we received reports, we still had to do investigations. And receiving the reports, that continued. But the challenge became with the investigation part. How do we perform those face-to-face visits? And not only that, if there was a way to contact our clients, how do we determine, like I talked about previously, of whether a person, when they refused our assistance, whether they had the capacity to make that decision or not? So let me jump ahead, and it didn't take long. Somewhere early in April, we have a good working relationship with Dr. Ronan Factora, who is on this discussion with us, and you'll hear from him later. He's a geriatrician from the Cleveland Clinic. He serves on our Adult Protective Collaborative, and he works very closely with a lot of my staff in doing some of those evaluations concerning capacity. So early on in the pandemic, like I said, he reached out to me personally to share that they were moving forward in the Cleveland Clinic world to doing virtual appointments with their doctors and working off of a virtual platform. And he asked very directly if it would be useful for Adult Protective Services if we sort of engage with using that service that they were providing. Well, of course, we were already running into barriers and seeing our clients and getting those assessments done because nobody was willing to see patients on a face-to-face visit. So we jumped on the chance and began working out a system where we could get clients unable to get one of the capacity evaluations on their own and started working out how we can get those virtual assessments to occur. And actually, it worked very quickly. By the end of April, we had in place a process by which we identified a nurse in our staff. We were able to do that, who would play a vital role in arranging and assisting those virtual visits. And the rest, as they say, is history, since this is still in practice. And one of the reasons we're doing this webinar to discuss the successes that it's occurred by doing this virtual assessments.
Larry, can you kind of describe quickly what would be an ideal APS client for a geriatric assessment done this way?
Okay, so I'll look at the model or the approach we took during the pandemic period. Like I said, getting that face-to-face visit was such a difficult process, and it was difficult to be successful. Then arranging for their medical, reaching out to a medical professional and getting that assessment done. If we witnessed somebody who had a concern concerning their capacity, and maybe they didn't have that regular physician they could go to, we could then ask them during the course of the visit if they'd be willing to do a virtual visit with a physician. If they were willing to do that, then one of my staff would then proceed to reach out to the Cleveland Clinic doctor through our nurse to get that capacity evaluation done in the home. And it means that that client doesn't necessarily have to leave. Maybe there's some ambulation concerns, maybe some other health problems that they're running across that they can't even transport. Plus, too, like I mentioned, many places weren't taking clients inpatient or even having them come to the clinics as an outpatient. So that would be a circumstance where we would reach out and pursue the virtual assessment route.
That's great. I think it's good to emphasize that this isn't just for every APS client that comes through and is reported to us here in Adult Protective Services, but it's really a specialized client who may not be connected already to medical care. And like you really stressed throughout what you've been discussing, somebody really who shows some declines and cognitive concerns that we're witnessing, and we really need that further kind of extra step to get them to a point where we really address what may be truly happening and get them a diagnosis. Lastly, Larry, just to sum up, what would you say are the 3 most beneficial things that you've thus far encountered as a result of this collaboration?
Well, first of all, closer working relationship with the hospital system. That's always a plus. It would be beneficial if some of the other hospital systems would jump on board and sort of assist too, because of course, because of insurance restrictions and such, some of the other hospitals are the main campuses that they would work with their particular patients. So that would be helpful. But once again, strengthening that relationship with the Cleveland Clinic. Sometimes time is of the essence with our clients. Sometimes determining, especially when we have somebody who's refusing our help, and it's clear that there's that a person's in harm's way if they don't get the medical attention that they need. And even though they're refusing us right off the bat, trying to determine as quickly as possible their ability to refuse that and determining whether they have the capacity to make that decision is an important piece. So this sort of expedites that a bit, because doing the virtual assessment can happen within a period of maybe just a week or a couple weeks, rather than making an appointment for somebody that could take about a month or two in order to get them in to see their physician or do an outpatient service provider, as well as two, now that the third thing I see is now that the pandemic period is over, we still run across, let's say it opens up where people do have the ability to go back to their medical staffs, to go to doctor's offices and such. We're still going to run across those people who are very hesitant about leaving their home, about going out in the community, and this is a great option and to go for and pursue in order to get somebody the help they need and the attention they need, and the assessment that needs to occur in order to determine whether we need to push the issue and get them the help that they need. Being able to do that in a person's home is very helpful.
Great. Thank you a lot for sharing that perspective, Larry, and just discussing what you have seen this past year or so with the utilization of this collaboration for your APS clients that are coming through from the community. We're going to switch gears a little bit now, and I'm going to ask Kelly Clemings, the geriatric nurse here at DSAS, a few questions. Thanks for joining us. Kelly, can you kind of explain to us the type of client that you're seeing and how you actually become involved with APS, how you're receiving the referrals?
Well, when this idea started, we kind of tweaked an already developed request form. So we have a request form that usually the worker has already seen the client and sees the need for either a medical evaluation, which would be me, a behavioral evaluation, or if they see the need for the geriatric assessment. And then that's filled out on the form. And then that's given to their supervisor and given to Larry, who kind of goes over it and sees if it's appropriate. And then it's forwarded to me.
So the unique kind of part about your role here at DSAS is that in addition to helping with organizing these appointments with Cleveland Clinic, you do a few things outside of the tele-assessment as well. Can you describe a little bit about the medical assessment that you do and also the behavioral assessment?
Oftentimes, like Larry said, during this pandemic, medical care has been non-existent for almost a year, and sometimes it's already been non-existent for a year. So we're talking 2 years they haven't seen a doctor. They'll want to, sometimes the worker will notice some skin problems. Maybe the client has told them that they have high blood pressure or diabetes, and I will go out and do a medical assessment, just a basic temperature, weight, blood pressure, assess their lungs, that kind of thing. And that's the medical portion of it. I also do the client's behavioral assessment. I do like a mini mental where I ask a few questions. I also do medication counts to see if, what they were taking, when it was prescribed, if it's, outdated. And that the geriatric assessment, I do several other things involved with that we can go into.
So can you kind of walk us through what you do when you specifically are engaging in the geriatric assessment and partnering with Cleveland Clinic and one of the 3 doctors who really provided these assessments this past year?
Well, that's been another good thing. We've grown so much that we've added 2 doctors. So Dr. Factora has some assistants, one on the west side and one on the east side in case, a referral needs made for them to follow up there. So that's been good. I get the request form from Larry, and then Dr. Factora's office assistant, I have a certain representative for each doctor that I contact so that I don't really have to go through the whole Cleveland Clinic referral for an appointment, which has made it fabulous. I mean, I have an email whoever the doctor is as representative. She usually gets back to me within, 2 to 3 days, sometimes the same day. The worker has provided a little bit on the request form as to what the APS issue was and why they need the geriatric assessment. After I get that scheduled, I let the worker and the supervisor know. I let Larry, I think a joint email to everyone about what the the time and the date. It's then the worker's responsibility to call the client or the family representative to make sure that I can get access. Once I'm allowed access, I go by myself. I take the little tablet we were given, and that's when the process starts. I usually go because I have no real medical background on these people. The only thing that they've really been given and what the doctor's been given is Medicare, Medicaid number, and just the basics that the worker could find out. So I try to go early. I'll arrive, I explain the process, and in most cases, I would say that the clients have been good about access, and they actually seemed, I wouldn't say excited, but happy that I'm bringing a doctor from the Cleveland Clinic into their home. Most of them have been very cooperative. So I will explain that to them. I get a consent sign that includes APS, the contact person, their family, Dr. Factora, Cleveland Clinic, virtual assessment, or whichever doctor. I get that signed, and then I kind of explain to them the doctor. Many times they'll ask me, when's the doctor going to be here? I'm like, he's on the tablet. And then I kind of show them. I get their vitals. And the beauty of this is these APS clients, sometimes their environment is the key to, why we're in there. We get a lot of calls about hoarding, that kind of thing. But I can see their environment. And oftentimes people are a little more open when they're in their own home than when they're at the doctor's office. So that also helps. I kind of ask them, well, tell me about your day. I mean, how do you get around the house? And I can see they'll show me their bedroom, and I can get an idea of, they're sleeping on the floor, or I can get an idea of where they keep their medicines. I can get an idea of where they have food. So I can get all those things. And also another thing Dr. Factora likes to have is a pill count. Some of these medicines, it's 2018, and the bottle's full, and they're supposed to be taking it for their diabetes. So we're kind of, helping him realize that they're not compliant with their medical care for, several years. I look at the prescription, I look at the date, the amount. I take their vitals. And another thing that Dr. Factora is interested in is their weight. Sometimes we don't have anything to compare it to, but I will get a weight. I have a scale I'll carry around with me, because that tells a lot to him about, their nutrition, that kind of thing. Another thing that Dr. Factora and the other doctors using the EPIC system are allowed to see clients that were in the Metro system, so he can kind of see if they've been and when they've been, what medicines they were on, and kind of hopefully a little bit of medical background. And then turn the computer on, and we start the process, and he asks them the questions, and he does the testing, and I assist him with any papers that need physically handed to them.
I know that we discussed several cases that you've gone out on, Kelly, and I recall a case where there was some issues with a pet. So I know you spoke about how important it is to get into the home environment, to do that pill count, to actually physically lay eyes on skin integrity,
right,
and if there's wounds and things of that nature. But, I thought was really interesting about just looking at not only like the nutritional part of the client themselves, but also with the pets that are underweight or overweight, because the client may be experiencing dementia and some cognitive decline and are overfeeding or underfeeding pets. So I can't stress enough the value it has, for our APS clients on our side of the spectrum, how valuable this has been. Along with that accord, can you briefly describe one of the success cases here with adult protective services?
I want to add some other things that I look at that are important. He will ask them if they drive, and sometimes I'll take pictures of the car. They'll say, I don't have any problems, but the car's dinged and scratched, and so that's been in some accidents. Also, I look at their clothing. I had a case where I saw her twice. She had on the same clothes. She had her shirt on backwards. And the first time I asked her, she said it was more comfortable. So I'm thinking she's wearing the same clothes for 3 weeks at a time. So clothing, cars, and the pets, like you mentioned. You asked for a success story. This was a lady who came in. She was the she was referred. The worker had seen some issues with her clothing. She'd gotten lost, medical compliance. The house was falling down. So we set up the geriatric assessment. And while we were in the home with the geriatric assessment, the husband was also there. This is a couple that were at one time teachers, intelligent, but his actions, I didn't realize there was a husband that we needed to be involved with. But during this whole time, his actions, I could see that he also needed a geriatric assessment. So we kind of, I think he was trying to outdo his wife, assessment-wise, number-wise. So he agreed to have an assessment. So we set that up, and we got that accomplished. And it turned out that they moved. They had a very nice nephew who was very involved. Before he moved them to Florida, he set up a primary care. He made sure that things were done here, that his medical records were transferred. And both of them were moved to an assisted living, I believe, in Florida near him. So they were still able to be together, still able to have some independence in a safe environment. So I kind of thought that was a positive, even though they both required a guardian.
Exactly. And there are outcomes like this actually that occur constantly in adult protective services. I don't think that people realize that enough, but I think a great foundation is to really, like you said and Larry mentioned, capture what is truly going on and how we can intervene to get those people safe and hopefully alleviate any of the abuse or neglect or self-neglect and exploitation that's occurring. So thanks a lot, Kelly, for being a part of this.
You're welcome.
I'm going to move on to Dr. Factora. He's kind of the last link to this whole project. Thanks for joining us today, Dr. Factora. Can you tell us about your work that you're doing currently at the Cleveland Clinic as a geriatrician and a little bit about the other doctors involved with this collaboration?
Sure. So a geriatrician is a doctor that takes care of patients who are 65 and older. And typically we deal with the disorders that are associated with aging, like memory concerns, unexplained weight loss, falls, concerns about medications. Our goal is really to preserve function and preserve independence. Invariably, we'll end up encountering cognitive impairment or dementia of some form or another. And along with that, we'll probably encounter issues of self-neglect, neglect, and financial exploitation. So there's a lot of overlap between the things that we do and the need for collaborations with agencies such as Adult Protective Services. And myself and the two other doctors that I work with on this kind of mission, Dr. Swarna May and Dr. Amy Hall, have seen a lot of these cases and know the value of working with APS and making sure that these individuals are assessed and making sure that their needs are met and developing a plan outside of the medical realm to make sure that their needs are met. So that's essentially what we try to do on a regular basis, just to preserve a person's independence and function, and achieve that through working with their families or working with community agencies that can meet those needs.
So could you describe a little bit about how you conduct the assessments for the clients in APS that are referred on to you and the other doctors?
Yes. So typically, just to follow up on the things that Kelly had mentioned a while ago, once we have a case identified, those individuals actually show up on my schedule, and it's an hour-long evaluation. And the components that I actually address are related to assessing their functional status, assessing if there's any cognitive impairment, and determining whether or not they have any insight that there's any problem at all. Now, typically, when APS is involved in these cases, there's already a problem. Someone's identified a concern, and what I'm trying to see is whether or not that person actually recognizes that there's an issue altogether. So a lot of the process involves asking the client, the person, a lot of questions. So the first part is really to determine whether or not there's any cognitive impairment. So we administer, with Kelly, a battery of cognitive tests, and it includes the St. Louis University Mental Status Test, which is SLUMS test, which is very similar to the MOCA or the Many Mental State Examination. It's just a broad assessment of cognitive functioning, score out of 30, and if you have abnormal tests, then there's a concern there. We also have very specific tests testing executive functioning and visuospatial skills. So those are the clocks tests. We have a person try to draw a clock, and we provide them a circle and see if they can draw the numbers and put in the correct time. We also see if they can do it spontaneously, and there's a score there that assesses how they do. We also have that person do trails making tests. So, if anyone's ever seen the trails making test, there's two forms, trails A and trails B. And essentially for trails A, it's just a set of numbers in a piece of paper, and you have to connect the dots, in order from 1 to 1, 2, 3, 4, all the way up to the end, and see whether or not you can do it without errors and in a fixed period of time. The more complex tests actually have you alternate numbers and letters in order in the field the same way. And that really identifies individuals that have problems with executive functioning. And that's the part of cognitive functioning that really is very important in synthesizing data, solving problems, setting up an order of things that you have to do during the daytime, keeping track of multiple tasks. Really important when you're thinking about a person's ability to drive, the person's ability to manage their finances, the person's ability to manage their medications, and pretty much take care of themselves at home. If that's impaired, then that would really help to support the reasons why a person is having problems at home. So beyond the testing, I also ask whether or not the person realizes that there's any problems at all. So I ask them, do you drive? Do you manage your finances? Do you manage your medications? Do you prepare your own meals? And then I ask them whether or not they've noticed any problems to see whether or not there's any corroboration between what the person actually thinks is going on at home and what I've told. So the collateral information I get from Kelly, from APS, is very important in terms of what has been observed, what problems have been seen, because usually there'll be a problem with a person paying their bills. There will be a problem with a person taking their medications. There may be a problem with a person actually eating regularly and then losing weight. So all that information that I gather from Kelly about the pill count, about the weight, about the bills, and whether or not there's problems that's been observed elsewhere helps me when I'm trying to understand whether or not that person understands that there's a problem at all. And pretty much when I ask my questions, I have to be convinced by that individual whether or not they really are doing the things that they say that they're doing. Does it sound that they're really paying their bills on time? So I ask them specifically, what bills do you pay on a monthly basis? And I have to be convinced that they really understand what bills they're taking. I ask them, are they taking any pills? Are you making any mistakes? Do you miss medications? Do you double take medications? And I compare what they say with the pill count and the age of the medications that are at home. And I ask them, are they going to the grocery? Do you have a lot of leftover food in the refrigerator, or do you have problems getting food? And then I compare that with Kelly's observation of spoiled food in the refrigerator or an empty pantry. Or if there's a weight loss, if I have a weight from their medical record that shows that in the last 6 to 9 months since they were last seen by the doctor, they had lost 10, 15, 20 pounds, despite the fact that the person insists that they're eating on a regular basis. So I'm looking to see what that contrast is, and that's all really to assess insight that there is an issue. And then I ask them also, if there was a problem, who would they trust and what would they do to make sure that their needs are met? So this is a kind of way to show whether or not they have a plan to meet their needs, if there was a deficit. And that's what I look for these evaluations, problems with insight that there's an issue and seeing what their plan is. And then, if there's problems in those areas, that's where I actually work with Kelly and with APS to see how we can fill in those gaps, because probably that individual is not able to meet their care needs independently and they need help, whether they realize it or not.
Could you talk a little bit about the expectations that come out of the assessment, especially when you find that somebody does have some impairments that require addressing? What are some additional things you may recommend as a physician to the APS worker?
Right. So I don't like to close the case until I know what's going to happen afterwards. And usually when I can see that there's an issue, whether there is cognitive impairment on my cognitive testing or there's problems with insight and judgment and their needs are being met, then we need to develop a plan about how this is going to be followed through. If I can see that the person actually has medical care through my access to the electronic medical record, then I recommend that that person goes back to that provider. And if there hasn't been any workup done for the memory problems, I recommend that be done, because there is a standard battery of tests that are recommended to evaluate a person with memory loss. And if the tests have been done based on the medical record, then there's nothing else that needs to be done. But probably if there is dementia, I suspect there's dementia, that has to be brought to the attention of the primary care provider. So at least connecting them to the medical provider that they have is going to help to continue that medical workup and following them over time. There have been cases where that person has not been connected to medical care for a number of years, sometimes 5, 10. There's one that was 20 years, one that has never really seen a doctor since they were much younger. So trying to see how we can connect them to the medical facilities in Cleveland is important. And that does require collaboration with APS, sometimes collaboration with family. So just getting a date for a medical evaluation is one of those outcomes that I actually want. And then, my ask of APS is to make sure that there's follow through, that they actually did make it to that appointment. And once that connection is made, then the onus really falls on that primary care provider to follow through on the things that we identify. And the concerns can be communicated to that provider when there's a handoff, and then the rest really falls on the shoulders of the provider, unless there's the APS case remains open and APS continues to be involved. There are a handful of situations where there's very limited access to medical care, and there's no established care, and there's no one else who actually has been connected, in which case I arrange for those folks to come back and see me in clinic. That way, at least I can make sure that that person gets the medical care done. And we've run into a lot of challenges there with regards to transportation, patients forgetting to make the appointments. And it is a lot of work. Kudos to Kelly for really following through and making sure the medical workup is done. But from my perspective, before I close the door from the medical evaluation, I have to make sure that they're connected. And then afterwards, I have a debrief with Kelly to make sure that we understand what's been going on with that individual, and then develop a plan. We implement the plan, and then, if necessary, I'm ready to complete a statement of expert evaluation if guardianship is to be pursued. All of this is really meant to make sure that that person's needs are met, and given the fact that they probably have been neglected for quite a period of time.
What I found interesting is, when we first started this, oftentimes you were also asking for lab work. Can you say why lab work is sometimes important to this whole process as well?
So the lab work is important when you're really looking at individuals with memory problems. We're looking for reversible causes. It's a small fraction of causes for cognitive impairment or dementia are reversible, but if there's something that we can fix, and it's easily fixed based on the lab work, then we should go ahead and pursue it. The other thing that the lab work may uncover are medical issues that have been untreated or undiagnosed for a long period of time, like chronic kidney disease or diabetes or anemia of unclear etiology. Those things really need to be worked up, because there can be really long-term impacts if a person's kidney function is not preserved, if their diabetes is not under control, and if we don't identify a cause for a person's anemia. And then if they're losing weight, that's another medical issue that needs to be addressed. So the lab work may reveal a cause for that, whether it's going to be anemia that may suggest that there's an underlying malignancy, or a thyroid problem that is going untreated, or really severely uncontrolled diabetes. All of those can lead to weight loss, and they can be addressed medically. So the lab work is really an important component of that work.
So we began this particular arrangement in April of 2020, and it really stemmed from a conversation that actually Larry and I had with you. And, for us here in Cuyahoga County, it's been a blessing, and it really has assisted us throughout these past, 14 months in the way that we're doing business with APS clients. What do you think the future of teleassessment is in our world today? We've seen the benefit of it, but where do you think this is going in the long run, Dr. Factora? So,
even after the pandemic is done, I think that these virtual assessments are going to be a fixed component of at least our clinical care at the Cleveland Clinic. We've found this to be valuable service for patients. I think that the collaboration with APS has been very fruitful, very worthwhile. And it reaches out to those individuals that either don't want to go and see a doctor in the clinic or have difficulty leaving the home. So it really catches a different group of people that could actually come into our clinic. And I think that there's always going to be those individuals that do not have the ability or the opportunity to have a geriatric assessment done in person. So I think that that will always be the case. There's clear advantages for this. And so I think it's going to be ongoing, even after the pandemic is done. Now, there are some disadvantages, of course. You know, we have technology limitations. We run into some barriers with bandwidth when we go to these places. Not everyone has the internet, and things are slow. Patients can still refuse as well for this to be done. And there may be information that's really lacking. You know, for those individuals that have been socially isolated, unbefriended seniors, have very little information available. You know, getting that collateral information can be a real challenge. And that's why I really do rely on APS to get that background information, because I have no family, I have no friends, I have no other individuals that can tell me anything about the person I'm seeing in front of me, aside from what APS does. So there's a clear need for this. I think that you know, for the clients that APS sees, that this is a service that clinicians can continue to provide on a regular basis to help to meet the needs of these older persons that are really having struggles in the community, and we can really develop outcomes, provide outcomes for those guys that are going to be positive. And I think that if we review the data for the patients that we've actually been able to see over the last year that we collaborated on, we'll see a lot of successes.
And I couldn't agree with you more. I know, just personally speaking from the APS perspective, we get something called a protective service order, and we've used those in the past with difficult clients that we weren't able to have go to see a physician to get a geriatric assessment completed, or, you know, we're just those kind of people skipping appointments once they were made. And I think that, you know, we're still doing protective service orders, but not as much for actually getting the geriatric assessment completed. So again, this has really benefited and impacted the work we do here in Cuyahoga County with our Adult Protective Services program. So that concludes our presentation today. I'd like to thank our panelists for sharing this valuable information with us. We hope through this discussion, we've been able to provide you with some perspectives of the geriatric teleassessment and the impact on the work that is being done in adult protective services with the clients we serve. Please feel free to reach out to any one of us on this panel with questions. Our contact information is on the screen and will be provided, both our email address and our office number. Again, you know, we thank you all for listening in today on this Facebook Live. We are hopeful that, you know, what we've begun here in Cuyahoga County may even be replicated throughout the state of Ohio with other adult protective service programs. It is so important to collaborate with all your resources in your community, especially any of those that are really tailored to getting, you know, medical attention for our clients, getting them really comprehensively seen. Geriatric assessments have proven to be very valuable in dealing with many of the clients we're serving here in Cuyahoga County. So thank you again for joining us, and thank you to our panelists. Have a good day.
Take care.